Let's go to case 2, and again, what we're going to try to do is kind of move through some different scenarios, taking into account different clinical presentations as well as how they fit into the guidelines. So case number 2 is a gentleman in April of 2009 who's a 53-year-old Caucasian male who was referred to urology for a PSA of 15. He has a family history of prostate cancer, has some comorbidities of hypertension, undergoes traditional sextant biopsies, has a prostatic volume of 68 grams, 8 of 12 cores positive, Gleason 4+4. Has a metastatic evaluation including technetium bone scan and CT, which are both negative. So Chris, in the new AUA guidelines, he is index patient 1, correct? So he's non-metastatic. He's got a PSA of 15. Take us through this patient initially if he presents to you. What kind of options are you going to discuss with this gentleman?
Yeah, so he's high risk with his new diagnosis, but staging negative. And historically, we often felt that a high-risk patient should see radiotherapy with androgen deprivation because there's a chance they have microscopic disease statistically. But, you know, I think that the fact is we're looking a lot more at multimodal therapy now, and we use the concept of pathologic staging to help determine should they have adjuvant therapy of radiation, should they have androgen deprivation for node-positive disease. So in the castrate-sensitive high-risk patient that's not going to go into a clinical trial, surgery has, I think, gained some traction in the last decade because of that.
Joe, would you agree with that?
Yes, I would agree that high risk, we're trying to bring younger, healthier patients to surgery with the understanding, and we counsel them this way, that there's a good chance you'll need radiation afterward, but this is going to be the best pathologic evidence we have to go forward.
Okay. So this patient undergoes a radical prostatectomy with bilateral lymph node dissection in May of 2009. His final pathology reveals a pathologic T3C lesion, which means he has seminal vesicle involvement. He is N0, M0. Postoperatively, his PSA nadir is at 0.5. He then is watched carefully by urology. PSA goes up to 1.1 6 months postoperatively. He then receives adjuvant radiation therapy to his prostatic bed. He then nadirs again in July of 2010, and we see here a series of PSAs post-radiotherapy to the pelvis of 0.3 in July of 2010, 0.5 in July of 2011. In November of 2011, he's spiking again. He goes to 1.6. He gets negative. He undergoes a restaging evaluation, which is negative. He has androgen deprivation therapy initiated in February of 2012. So now he's 3 years postoperative. PSA again nadirs to less than 0.01, but again he starts to rise with a PSA of 0.5 nanograms per ml and a testosterone level in the castration range. If you look at his chart, it's charted here on this graph, on this graphical presentation. We see his time frame here. So he gets surgery, adjuvant radiotherapy to the pelvis, androgen deprivation therapy, and then again, now in October of 2013, his PSA is now at 2.5.
Just going back just to the urology component, I don't know if he had positive surgical margins or not, but it's interesting because detectable, I believe, at 3 months after surgery. His first PSA is 0.5, and 3 months later it doubles. And I would really take that to be metastatic disease, and I would be a little reluctant to think he's going to get much benefit from adjuvant radiotherapy, of course, based on his margin status, which I'm not sure what it was. And I'm surprised he got that degree of response, so good for him. But I'm just saying that clearly looks like he had metastatic disease outside of the pathologic nodes at the time.
Joe?
Yeah, I agree that if you are not nadiring to undetectable, that's certainly an ominous sign. And then with regards to radiation therapy, I know they were probably delaying here because he's trying to get his continence back, but certainly we try to use adjuvant radiation therapy before PSAs certainly reach 1 and more so under 0.5.
But can I just ask, as a non-urologist, you use the term adjuvant. I mean, usually, at least in medical oncology, if a PSA was 0.5 post-op, that would no longer be considered adjuvant. It would only be adjuvant if the PSA was undetectable post-op. So I don't know if there's
So if someone goes to undetectable and then has a biochemical recurrence and we use radiation, that's a salvage radiation.
Right.
Technically, I
Right.
would agree with you that he never went undetectable,
Right.
so it's salvage up front.
Yeah, exactly.
Yeah. Yes.
Small point.
No, it's important, I think.
So when he responds initially to androgen deprivation therapy, and now again towards the end of 2013, he has these rising PSAs. To the panel, what are the triggers? So now this patient is in this castration-resistant prostate cancer range where he's got prostate cancer, his PSA is rising, his testosterone level is in the castration range. What is sort of your triggers when to start looking for metastatic disease? Do you have a trigger? Is it by PSA only? Is it clinical symptomatology? And is there a value of your PSA when you would start to re-image?
Well, probably a baseline bone scan would be a good idea. It could also help you sort out if they had any other reasons to have findings on bone scan that you could sort out, such as fractures or DJD or something. But the doubling time will be useful as well, and a PSA doubling time less than 10 months, I think, will prompt you to look more frequently in this disease space, because certainly finding metastatic disease would entirely change the options for the patient, and that's really important that we don't miss it. And I think from a urology standpoint, if you aren't really staying on top of this, the patient may all of a sudden present with symptomatic disease, and now the portfolio of treatment options may have changed to the right if they have symptomatic disease rather than minimally or asymptomatic disease. So we need to be a little more attentive during the early part, make sure we aren't missing metastatic deposits.
So that brings up a question, though. I mean, clearly this guy has bad disease. I mean, that short of a duration of response to ADT usually means something bad is going on. So one of the things that I think of in this situation is there a reason that I might want to identify metastatic disease sooner rather than later, especially knowing it's bad disease? And, you know, one of the ways of doing that might be not to use a regular technetium bone scan, but to go with an F18 PET bone scan.
We've used sodium fluoride PET. I think the NORPOR database has recently closed, so it's become more challenging to get those approved. But I agree with you that there may be a better sensitivity in that setting. I think also I would advocate that for the M0 castrate-resistant patient, they're the real patients we need to try to get into clinical trials.
Yep.
And we have ongoing ones now, which are exciting, and I hope that we can fill those.
So, right.